Before viewing video lessons, it is important to read the textbook using the learning guide as your turn-by-turn directions. Then use the learning guide to take organized notes in your own words with examples and pictures.
Of this, we were in the middle of talking about the integrative etiology of the depressive disorders. So we talked about the biological vulnerability, but that by itself doesn't mean you're going to get depression. We talked about the psychological vulnerability, and that by itself doesn't necessarily mean you're going to develop depression. And what we didn't quite get to is the final psychological, psychosocial dimension, which is stress. So I have this general biological vulnerability, this general psychological vulnerability, but what seems to be the thing that tips some people over the edge versus others is stress. Stress, 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 stress. Depressive episodes are most commonly preceded by a life stressor. Now, in some cases, this is a single big life stressor. We call these major stressors that externally you can look at that person's life and you can say, oh my gosh, you got fired. That's a big stressor. I can see that. But it can also be preceded by an accumulation of more small things that kind of become straws that fall on the camel's back. And so eventually it just takes one teeny tiny straw to sort of put that person over the stress edge. The model that we most frequently use is going to be the reciprocal gene environment model. And this is one that we talked about way at the beginning of the semester. So with the reciprocal gene environment model, what we think is that not only are people with this underlying vulnerability, kind of just walking around at risk if stress happens to happen in their lives, but that some of those underlying biological vulnerabilities also influence people to make decisions that put them into more stressful situations. And so it's not just, I'm walking around with this vulnerability and by happenstance or luck, I happen to step in the right or wrong stressful situation. It's that biological vulnerability is causing me to make decisions that make me more likely to go down the stressful path. And so there's a kind of a interactive relationship there between just general life and the decisions that people make in their own lives. So the type of stressor that we see most often preceding a depressive episode is a relationship-based stressor. So having an ending of a relationship, and this could be through a death, that's an ending of a relationship, or it could be a breakup. It could also just be ongoing relationship stressors. So marital problems are the biggest predictor of depressive episodes in men, for example. It's important to think about the distinction between depression and grief. And the way that we think about it in terms of depression is that death is a specific type of stressor. It's a relationship stressor. And depending on how close you were with that person, it's also a significant life change stressor. So if a spouse dies, if somebody who lives in your home, if you're a child, if it's your parent, or a parent if a child dies, those cause significant life change disruptions as well. And so grief after death is normal. It's not pathological. It's not the sign of a disorder. But deaths can be a type of stressor that can trigger depression. So the old version of the DSM used to have this kind of distinction. It said that we're going to wait 6 months after somebody dies before we diagnose you with depression. That is actually a bad thing, because what that led to was people not getting treatment when they were clearly experiencing the full criteria for a depressive episode. And remember what we talked about last time, about what we know about what happens in the brain and how important it is to get treatment because of what's happening in the brain and the hippocampus. And so the new DSM-5, the DSM-5 here, says if a person meets the criteria, whether or not the trigger was a death or not doesn't matter. If they have been in that severe, depressed, most of the day, every day, low energy, sleep disruptive, appetite disruptive, all those things Michelle talked about last time, for 2 weeks or more, we are going to call it depression and we are going to treat it. Because not treating it is actually causing more suffering and potentially setting this person up for a chronic recurrence of depression throughout their lives. So that doesn't mean everybody who feels sad meets the criteria for depression. And you can even temporarily, have a week, maybe even 2 weeks of criteria that dips down to the major depressive episode criteria, but then, dips back up, comes back up. So not everybody is going to get this diagnosis. So about 10 to 20% of people do meet the criteria for a major depressive disorder after a death. And it varies. It varies, again, by who died, but also by your own individual vulnerabilities that you're carrying around. And also, what's your overall stress level? So if you're walking around kind of overall at an elevated stress level, that death could just be, again, that straw that breaks the camel's back. It's just a big straw that kind of falls down on top of you. There's also a social dimension to this. We talked about the relationships being one of the big stressors, and a little bit of a cultural difference as well. So one of the things that we know is that people who have a robust social support network have reduced risk for depression. People who lack social support, that kind of predicts particularly late onset depression. So that would be past those teenage years, when you've moved out of maybe the support network you had inside your home, you're out on your own, you don't have a support network in adulthood, that puts you at risk. Support also impacts recovery. So even people with great support networks can develop depression. Those that have those great support networks tend to get better faster and are at less risk for recurrent episodes. There are some difficulties in diagnosing depression because there are cultural differences in how people express outwardly sadness and depression. And so sometimes the rates of diagnosis are different in different cultures. But we think that part of that has to do with a lack of understanding about what sadness looks like in different cultures. Is it culturally appropriate for me to show the world that I'm struggling? No. So I'm going to mask it, I'm going to hide it, and that's going to influence diagnosis. We've already talked about the biological difference, that women are much more likely to be diagnosed with depression. We think that some of that is biological. We also think that it also is related to how the role that relationships play in men's lives versus women's lives, and how relationship and social disruptions could potentially be more stressful for women than it is for men. Some of that may be how we're socialized. It may be a product of sort of our time and space and history and how women and men's lives are different, and the roles that are deemed to be appropriate for men versus women. But we do think there is some underlying biological differences. Again, last time we talked about the differences in the inheritance rates, and that might be related to some female genes. One of the last things I want to talk about in terms of etiology is that the rates are different at different points in the lifespan. And so we think that developmental factors, which are both biological, psychological, sociocultural, everything changes as you age, play a role. So we know that kids can have depression, even really young kids. So we can see symptoms of depression in kids as young as 3 months old. But the symptoms that kids have, and we talked about this a little bit last time with that disruptive mood dysregulation disorder, they may come out more as acting up and not minding and listening and not paying attention. And so some people think that there are a small number of people who are diagnosed with ADHD or conduct disorder because we don't recognize that it's depression that's fueling their disruptive behavior. We also see that the rates of diagnosis spike up after puberty. And again, we think that's partially related to the final phase of development in the brain and the endocrine system, but also the unique stressors that start in adolescence. Now, depression in the elderly is less common. So people who've had a history of depression, recurrent episodes, those episodes are less likely as we get older. So people over the age of 65 are less likely to experience a depressive episode. Doesn't mean they don't, but less likely. We do see the rate of anxiety disorders goes up, and frequently people who've had a history of depression in late life, if they haven't already had an anxiety disorder, they are more likely to develop an anxiety disorder in addition to depression. Again, some of that is because they have that same underlying biological vulnerability for both of these disorders. When we look at the gender differences in the elderly, the rates are less imbalanced, which is suggesting to us that female reproductive hormones could also be playing a role in depression. Because after menopause, men and women have more similar hormonal profiles in their body. Still not the same, but they're more similar. So, what causes depression? You've got these biological, psychological, stressful events, and that kind of fuels the development of depression. So in terms of treatments, we're going to start with the medical treatments that are available. And I'm going to go through these medications in more detail. We've been talking about antidepressants since we first started talking about disorders months ago. But I haven't talked about them in detail because this is the chapter where I talk about them in detail. The first antidepressants that we discovered were the tricyclic antidepressants. They worked by primarily blocking norepinephrine reuptake, but also indirectly affected other neurotransmitters like serotonin and dopamine. So by more norepinephrine in those synapses, so it's firing off a little bit more. So it's kind of a way to elevate the level of norepinephrine in the nervous system. These were a game changer the first time we had a medication. But these are not commonly prescribed today. They have a lot of negative side effects. They affect people's weight and sleep. And in excessive doses, they can be lethal, which doesn't seem like a good idea when you have somebody who has a symptom of thoughts of death and suicide as part of the diagnosis, to give them something that they could use to kill themselves. So today we only see these prescribed when we've tried everything else, and they're usually prescribed under a lot of controls. And so you can only get a few pills at a time. We're not going to give you, a 90-day supply. those, we developed the monoamine oxidase inhibitors, or MAOIs, and these block monoamine oxidase. I love it when the name tells you what it does. This is an enzyme that breaks down serotonin and norepinephrine. So after neurotransmitters are released and bind to receptor sites, they're usually sucked back up. There's a reuptake process that sucks them back up and recycles them. And anything that's left over gets neutralized by enzymes. So by neutralizing this enzyme, by keeping it from breaking down those neurotransmitters, we're going to allow more to stay in the synapse. So again, it's kind of trying to do the same thing, just under a different mechanism as the tricyclics. These were more effective than tricyclics. But again, today, this is not going to be our first treatment of choice, because when you're taking these, you have to avoid normal foods and drink because of a potential for a lethal interaction. You guys know about drug interactions, and you've probably been to the pharmacist, and they always want to know, like, are you taking anything else, because there could be a lethal interaction. And we understand drugs, but this one, you have to change your diet. So the next category that came out, and this is our current first medication of choice, not only for depression, but a lot of other conditions we've been talking about all semester long. I've mentioned SSRIs all over the place. So this is selective serotonergic reuptake inhibitors. This specifically blocks the reuptake of serotonin. So again, serotonin stays in that synapse, elevates that level. There are still some negative side effects, digestive issues, sleep, different types of appetite changes, things like that, but it has a lot less lethal potential than the other two, right? So the MOI, I could accidentally kill myself because I eat cheese, right? The tricyclic, again, if I take too much, it could have been lethal. So this is what we prescribe more than any other of the antidepressant class medications. It's commonly prescribed for anxiety disorders, some of the eating disorders we talked about, sleep disorder. I mean, we had tons of disorders we talked about where we've said SSRIs, SSRIs over and over again. The newest category are mixed reuptake inhibitors. These block the reuptake of norepinephrine and serotonin, but they're different from those original tricyclics that were primarily blocking the norepinephrine. They don't have that same lethal potential. They also have fewer side effects compared to the SSRIs. And so these are kind of increasing in popularity and in first choice medications. So, well, yes and no. Half of people get some symptom reduction. Only a quarter of people will experience a full remission of that depressive episode with medication alone. So they help about half of people, and about a quarter of people, they get all the way better. However, it takes 2 to 8 weeks for people to have a therapeutic effect from those medications. So it's not like a happy pill. I don't pop a Prozac and all of a sudden, everything's fine and great and wonderful. You've got to take it for usually at least 4 weeks before you start to get those effects that are helping. Most of the time when people start an antidepressant, we recommend that they take it for at least 6 months. We want them to get that therapeutic effect, and we want them to be well past that depressive episode before we would take that medication away. We also don't want anybody to suddenly stop taking the antidepressant sort of cold turkey. That can trigger a lot of unwanted side effects and can also worsen the depression. So we want to make sure that people are kind of slowly tapered down from whatever dose they worked up to. And oftentimes it's a little bit of experimentation with each individual person about which antidepressant at what dose works best for you. So it may take a couple of months to even figure out what the right drug is and what the right dose is. We do prescribe these to kids, but we don't have a lot of clinical trials about what the right dose is, which medications are best for kids. And there is some concern that these medications can increase the risk for suicide, and we see this mostly in teenagers, but it can happen in anybody. There's a lot of debate about why this happens. Part of it, we think, is related to how these medications influence serotonin. We know that serotonin levels can increase your risk of being impulsive, and suicide can be an impulsive act. So it may be because the serotonin is kind of going through this manipulation, it increases impulsivity as a part of the treatment. It may also be that people feel horrible when they're in the middle of that depressive episode. Their energy is so low. They may be thinking about suicide, but really lack the concentration to even think of a plan and the energy to follow through with that plan. And then they get some treatment, and their concentration and energy level starts to boost up a little bit, but they still feel sucky, and they still think about death. And so now they feel horrible, but now they have the energy and the thought to actually do something about it. So we're not exactly sure what's going on there, but we do know it's something that we need to be aware and concerned about. Okay, so what about other drugs? Well, here's one of the really interesting things. Hallucinogens. We've been researching the use of psychedelics for the treatment of depression. And actually, in March of 2019, we had the first approved psychedelic medication for the treatment of depression, called esketamine. It's a form of ketamine, and it's a nasal spray. So anybody who used Flonase or any of those nasal sprays for allergies, it's similar to that. And it's only approved for people who are taking a traditional antidepressant, but it's not doing enough for them. So it's in addition to that. And it's usually at this point administered in the doctor's office. So it's not like I can just go down to Walgreens and get a little bottle of esketamine and walk around and dose myself with ketamine anytime I want. So it's still pretty tightly controlled because reported significant struggling, and the antidepressant hasn't worked by itself. That's kind of cool. Another medical or biological intervention is electroconvulsive therapy. Now, the original shock therapies didn't use electricity. The first shock therapies we developed were insulin shock therapies, where we manipulated people's blood sugar levels until they had basically a seizure, which could be followed by death if they didn't get their blood sugar levels corrected. That wasn't very safe, so then they switched over to electricity. The initial doses and frequency of treatments, we didn't know what would work. And so there were some very unethical uses of electroconvulsive therapy where people had much higher doses than they should have, much more frequent sessions. And so if you've ever seen the movie One Flew Over the Cuckoo's Nest, that's based on a real life account from somebody who worked in a mental health hospital at the time. And that was kind of what was happening in terms of electric shock therapy. That is not what exists today. So don't look at that movie and think, oh my gosh, that's horrible, it's torture. That is not what they do today. So today, the electrical current is very brief. It's designed to trigger sort of a temporary seizure. Think of a seizure as kind of an electrical storm wave through the brain. It's almost like hitting the reset button in the brain. Like, what's the first thing the tech support people say to do when you call them and tell them you're having trouble with your computer? What I always say,
turn it off and back on.
have you tried turning it off and back on? It's like, oh yeah, it's magically working now, right? How do we do that in our brain? So this is kind of like doing that, like reset to factory settings for the levels of neurotransmitters and the electricity and everything that's going on. And so what we typically do is we do these electrical shocks to trigger these seizures 6 to 10 times, outpatient sessions spread over weeks. What we find is that for the most part, there's very few side effects from this, especially when you consider the side effects from people taking medications. The primary side effect is some short-term memory loss around the time of the treatment. So they may not remember shortly before, during, or after the treatment session. They may report a little bit of a headache after a treatment session, but that's it. So comparatively speaking, it's not very many side effects. This is not the treatment of choice. This is not the thing that we do when people first present for depression. This is usually done in people who have severe recurrent depressive episodes that haven't responded to other forms of treatment. But it seems to be somewhat effective. Now, again, we're using it with kind of the worst cases. I don't know if maybe someday you would be able to go into your family doctor's office and, like, I always think of like those little hair dryers they have at the beauty shop, you know, you could like put this little device over people's heads and you could be like, okay, you know, Mr. So-and-so, I'll be back in a couple of minutes. And then, you know, you could leave. Like, have you ever had like tense muscle therapy before? Put the little pads on you and they're like, okay, if it gets bad, buzz me, otherwise I'll be back. And, you know, maybe someday we'll have that capability. But right now, this is not something that, you know, you could get just anywhere. Another similar form of treatment is called transcranial magnetic stimulation. And this is where instead of passing an electrical current through the brain and kind of a massive, just targeting the whole brain, we can do a much more precise targeting of activation of neurons using magnets. So magnets can generate an electromagnetic pulse. We can't do this into the deep recesses of the brain, but we can activate areas of the brain on the outer layer of the cortex using this. The main side effect from this is headaches. Right now, it's used primarily in research settings. This is not something, again, that you'll be able to go, you know, just down to your local doctor to get. Yeah.
Or do they like rub magnets? Like,
they don't rub them. They usually have like electrodes that are attached to magnets that are placed at very particular points. And then they turn on these magnets, and then between the magnets, they can generate electrical impulse between magnets.
so it's like the hat when you do like was it like a CT scan? Or like when they have like that? Like
No, it doesn't. It doesn't look exactly like that when
Is
they
it
do
kind
it.
of like the little?
It doesn't actually touch your skin. So these are, it's usually like a device and the magnets can be positioned kind of around you. So it makes me think more of like the dentist office where they have like equipment on these big arms and they can pull in like the light and stuff. So it looks a little bit more like
That
that.
sounds weird.
So those are our medical options. Psychosocial options. Cognitive behavioral therapy is the best psychosocial option. The specific type of cognitive behavioral therapy we use for depression tries to address those cognitive errors we talked about last time. So remember that depressive, pessimistic style of thinking? Making those thoughts more balanced, more realistic, less negative. The behavioral piece involves changing up people's habits. So it could be changing up their sleep habits. One of the big ones we do is increasing people's activities, social activities, and physical activities. Do you remember the research study I mentioned about the hippocampus and how people who didn't get treatment had hippocampi that shrunk? In the research study, they had treatment, 3 different possible treatments. So that all the treatment people had hippocampi that stayed healthy. One treatment group took antidepressants. The antidepressants will help protect against that. One treatment group had cognitive behavioral therapy, so that will help protect against that. They also had a third group that was prescribed exercise. Their hippocampuses stayed healthy. So all 3 of those were helpful in protecting the hippocampus from that shrinkage that we talked about. Interpersonal psychotherapy is therapy that's focused primarily on relationships. It's not couples therapy, although you can have couples therapy as a part of interpersonal therapy, but it's really helping an individual with a variety of different relationships. So oftentimes this is not just, oh, my husband and I are having issues. It's somebody who has a lot of relationship issues. Like my relationship with my mother is fraught, and my kids, and my husband, and like lots of relationships have issues. So both of these have similar effects to medications. So they help about half of people. About a quarter of people get all the way better just with the talk therapies. The thing about these 2 types of therapies is that they last longer. Particularly cognitive behavioral therapy seems to help protect people from relapse. So what we really don't want to have happen is somebody to have another episode of depression. Yay, we got you over this one, but let's never do this again, right? So how do we do that? Cognitive behavioral therapy is the best. Now, we've been talking all semester long about what happens if you combine the medical and the psychosocial. And in the case of the anxiety disorders, most of the time I said, not a good idea. PTSD was a little bit of an exception to that, but most of the time it was like, no, don't combine them. Depression is different. Combine them. So the treatment of choice, the best treatment if somebody's having a depressive episode, is get them into cognitive behavioral therapy immediately. Start the antidepressant immediately. And people have the best outcomes when they have both of those forms of treatment. Now, for preventing relapse, we want them to take that medication for at least 6 months, and it's really 6 months after they got better. So if it takes them 2 months to get better, now we're talking at least 8 months. And then when it comes time to come off the medication, to taper it down to lower doses a little bit at a time. And then again, the cognitive behavioral therapy reduces the risk of relapse by 50%, which is a lot. Another thing that we find is important in the treatment and prevention of all disorders that seems to be important for depression as those good neurological health habits. And we've mentioned these a little bit throughout the semester. We know that appetite is disrupted when people are depressed. So making sure they're eating healthy foods on a regular basis can help with their treatment. We also talked about sleep being an issue and how in some cases poor sleep could be the trigger for the depressive episode. So we want to make sure we're promoting adequate sleep. I've already mentioned physical activity being an important component in protecting the hippocampus. We talked about how stress and overall stress and then specific stress triggers can trigger relapse. So doing something to help with stress management. And then as always, don't poison yourself or bang your brain, because that's not a good thing to do.